Okay, so let's go ahead and complete this very long, intense chapter, chapter 15. So, we as the nurses now, we play a key role in helping the patients deal with the side effects of chemotherapy and radiation therapy. We provide a lot of support and a lot of education to the patient. So, before we ever start teaching the patient, family, and or caregiver, we have to make sure that we assess the patient's ability to process the information. Is the patient nauseated? Are they not feeling well? Are they just not up to learning? So we have to make sure we assess that, because it's information that the patient, the family, the caregiver, they should all understand. And if the patient isn't able to receive the education, and there's a family member there who will be caring for the patient, with the patient's permission, we can provide the education. Oh my gosh, my dogs. So we also want to make sure we customize the teaching to meet the patient's and the caregiver's learning needs. It's just like, as I have discussed with many students, we have to assess the way that the patient or the caregiver or the family members, how do they learn? Are they visual? Are they tactile? Do they read? Would they prefer to listen? It is important to find out the best way that they learn so that they can receive the information in the appropriate manner. Okay, so what we're going to move forward with is we're going to be discussing nursing management and nursing implications. So sorry, I can't get my words out today. So we're going to first start discussing the common side effects of chemotherapy and radiation therapy, okay? So, bone marrow suppression, fatigue, GI disturbances, skin and mucosal reactions, and pulmonary and reproductive effects are common side effects of chemo and radiation therapy, okay? So, we will move forward and discuss this in more detail. So discussing bone marrow suppression. So myelosuppression is one of the most common effects of chemotherapy, but not so much radiation therapy. So what is myelosuppression? This is where the bone marrow activity is decreased, okay, resulting in lower red blood cells, white blood cells, and platelets, okay? So these issues can result in life-threatening and distressing effects, all right? Issues such as infection, hemorrhage, overwhelming fatigue, okay? So the major differences or major difference in manifestation between radiation and chemotherapy is that radiation, which is a local therapy, as we discussed, it really only affects bone marrow within the treatment field, right? So if it's within the field, then it would affect the bone marrow. But because chemotherapy is a systemic therapy, as we've discussed as well, this affects bone marrow function throughout the body. So when the therapies are combined, the risk for myelosuppression, it greatly increases. For patients who are undergoing radiation therapy and chemotherapy, we want to make sure that we're watching their white blood count, okay? Because that is usually what is affected first. Then the platelets are normally affected, then red blood cells, okay? So, I mean, it makes sense that depending on the severity of the myelosuppression, really depends on the chemotherapy drugs that are used, the drug dosages, and the radiation treatment field. So we also, as nurses, want to monitor the complete blood count. Okay, we want to make sure when we're monitoring the CBCs, we are looking at neutrophils, platelets, red blood cell count. Okay, especially in patients receiving chemotherapy. So neutropenia. Okay, we know that our neutropenic patients, I mean, if you sneeze, it could kill them. So, which our neutropenic patients are much more common in those who are receiving chemotherapy than radiation therapy. Because of course, it is a serious risk factor for life-threatening infection and sepsis. So with our neutropenic patients, we should make sure that the temperature, that their temp is monitored routinely, and if there is any sign of infection, this should be treated promptly since fever in the presence of neutropenia is truly a medical emergency. We're also going to monitor for thrombocytopenia. This can result in spontaneous bleeding or major hemorrhage. Okay, so we need to teach the patient to avoid any activity that might place them at risk for injury or bleeding. And then with anemia, this is pretty common amongst our patients that are undergoing both chemo and radiation therapy. Okay, it usually doesn't kick until about 3 to 4 months after starting treatments, but we still need to make sure that we are monitoring the red blood cell count. And there are things like Epotuin, oh my gosh, Procrit, that can be given to assist with lower red blood counts, blood cell counts. So let's go ahead and talk about fatigue, okay? So the definition is it's a persistent subjective sense of tiredness that interferes with usual day-to-day functioning. But fatigue really is a nearly universal symptom that affects most patients who have cancer and receiving treatment, okay? Fatigue may also, and this is something we need to make sure we explain to our patient, fatigue may persist long after their treatment has completed. And something that we need to make sure we do is that we assess for any reversible causes of fatigue, such as anemia, hypothyroidism, depression, anxiety, insomnia, dehydration, or infection. So we need to make sure we assess for those things because we may be able to assist with the patient feeling so fatigued. So once again, it's important that we help patients recognize that fatigue is a norm. Okay, it is a normal side effect of cancer therapy. So we need to teach them how to conserve energy and teach them energy conservation strategies. So if we can help the patients identify days or times during the day when they're typically feeling better, we can encourage them to be more active during that time. Okay. We also need to make sure we educate the patient on resting before activity, and please to have others help with work or home tasks because it may be necessary. So we also need to teach that ignoring their fatigue or overstressing the body when fatigued is, they may be able to tolerate it, but it may lead to increase in symptoms. And we also need to make sure we inform our patients that maintaining exercise and activity with tolerable limits is often helpful in managing fatigue. Okay, so with GI effects or gastrointestinal effects, the cells of the mucosal lining of the GI tracts are highly proliferative, okay? So proliferation means that the cells to grow by rapid production of new parts, cells, or offspring. So overall, what that means is that the cells in mucosal lining, they reproduce very quickly, okay? And the intestinal mucosa is one of the most sensitive tissues to radiation and chemotherapy, okay? So the injuries that cause a variety of GI effects include nausea, vomiting, diarrhea, mucositis, and anorexia. These problems can significantly affect the patient's hydration and their nutritional status and sense of well-being. So let's go ahead and talk about nausea and vomiting, okay? These are pretty common effects of chemotherapy and sometimes of radiation therapy. So chemotherapy-induced nausea and vomiting can occur within 1 hour of receiving chemo. So vomiting may start a few hours after radiation therapy to the chest or abdomen. So anticipatory nausea and vomiting can develop if a patient has poorly controlled nausea and vomiting after chemotherapy administration. So aggressive emesis control, including giving prophylactic antiemetic and anti-anxiety medication 1 hour before treatment, is always recommended. So this is something we teach the patient to expect, and then we also educate them on anti-nausea or antiemetics and anti-anxiety meds that they may receive prior to their chemotherapy or radiation therapy. Okay, so nausea and vomiting can also be successfully managed with diet adjustments and other non-drug interventions, as well as the antiemetic drugs we just discussed. So diarrhea is a reaction of the bowel mucosa to radiation and some chemo drugs. So it's characterized by an increase in frequency and liquidity of stool. Okay, so as the nurse, we recommend a diet low in fiber and residue before chemotherapy. Okay, for and this includes limiting food high in roughage. So we have to teach the patient, okay, to limit foods such as fresh fruits, veggies, seeds, and nuts. So to prevent the diarrhea or other foods to avoid include fried, fatty, or highly seasoned foods and foods that are gas producing. So with mucositis, it's an irritation or an inflammation or ulceration of the mucosa, okay? So chemo and radiation therapy can cause mucositis. Patients diagnosed usually though with head and neck cancer who receive radiation are most at high risk. So we should, as the nurses, for these chemo patients, routinely assess the oral cavity, mucous membranes, characteristics of saliva, and ability to swallow. So having a dentist perform all necessary dental work before starting treatment is also recommended. So we need to teach the patient to also self-examine the oral cavity and how to perform appropriate oral care. So mucositis or pain in the throat can be eased by systemic or topical analgesics and antibiotics if infection is present. We also need to educate the patient, monitor, and get prompt treatment for any oral candidiasis, which is fungus, okay? Oral fungus. This often occurs with mucositis, all right? And so the next GI issue we are going to discuss here is anorexia. So the anorexia involving our chemo or radiation therapy patients is the loss of appetite, which is a common occurrence in patients with cancer. Okay, so anorexia is a side effect of the cancer as well as of cancer treatment. Anorexia may be related to an inflamed mouth or esophagus, which really creates difficulty chewing or swallowing. Okay, or to emotions such as anxiety or depression. Okay, it is always important to have a dietitian involved in the patient plan of care before cancer treatment begins. So, radiation skin changes. Okay, this is something also that commonly occurs. With radiation therapy, skin effects are local, occurring only in the treatment field. So radiation-induced skin changes can be acute or chronic depending on the area irradiated, the dosage, and the technique. So the skin-sparing ability of modern radiation, though, of the equipment limits the severity of these reactions. So erythema can develop 1 to 24 hours after one treatment, okay? It generally occurs progressively as the treatment dose accumulates. It is an acute response followed by dry desquamation. Okay, and I'm going to show you a picture. That is a picture. So this is a picture of dry desquamation, and you can look it up and get some more details on it. Okay. And if the rate of cell sloughing is faster than the ability of the new epidermal cells to replace the dead cells, then a wet desquamation occurs with the exposure of the dermis and weeping of serous fluid. So I have a picture of that as well. There's your wet desquamation. So the goal overall, okay, is to prevent infection and to promote wound healing. So protect radiated skin from temperature extremes. We have to teach the patient, do not use heating pads, ice packs, or hot water bottles in the treatment fields. We also need to let them know that they need to avoid constricting garments, rubbing, harsh chemicals, and deodorants since they may traumatize the skin. Okay? All those skin care protocols vary. Basic skincare principles do apply. Both chemotherapy and radiation have the potential to cause irreversible and progressive lung damage. Distinguishing between the complication and treatments and those related to disease is challenging. The effects of radiation on the lung include both acute and late reactions. Acute effects can be alarming to the patient because they may mimic symptoms that precipitated the cancer diagnoses. Pneumonitis. This is an example of a delayed acute inflammatory reaction that may occur within 1 to 3 months after completing radiation. Some patients may develop pulmonary fibrosis with or without prior pneumonitis, which is a late effect of therapy. The most common toxicities associated with chemo include pulmonary edema or fluid retention, hypersensitivity pneumonitis, interstitial fibrosis, and pneumonitis due to an inflammatory reaction or destruction of alveolar capillary endothelium. We need to make sure that we are educating the patients on all of these effects that chemo or radiation can have on their pulmonary system, and also discuss the damage to their lungs may be permanent, some of the signs and symptoms that they may go through, and the types of treatments that if they do go through these types of side effects, that we would be or they would be prescribed. And of course, we would then have to teach them how to use the medications, how to use them, how often, when to use them, and the expected outcome. So treatments such as bronchodilators, expectorants, or cough suppressants, they may need bed rest or possibly oxygen. The cardiovascular effects. Radiation to the thorax area can damage the layers of the heart, such as the pericardium, myocardium, valves, and coronary blood vessels. The pericardium, though, is the most common that's involved. Patients with pre-existing coronary artery disease are especially at high risk. It is imperative that we make sure that we get a baseline and periodic echocardiograms just to make sure that there is a way of tracking any changes to the cardiovascular system. Cognitive effects can occur at any time during cancer. These changes can also occur after treatment. The change in mental function, which is often described as patients as they feel like they're in a cloud, is commonly called chemo brain. Although the brain will usually recover over time, some of the effects can last a short time or for years. And the effects can be so severe that patients may be unable to be involved in activities and other things that they would participate in prior to receiving chemotherapy. Reproductive effects caused by either chemotherapy or radiation vary depending on the radiation treatment field and dosage, as well as the chemo agent and dosage, and say the person's age, who they are, what they have going on with their reproductive system. Treatment can cause temporary or permanent gonadal failure. Reproductive problems often occur when reproductive organs are included in the radiation treatment field and when alkylating agents are used. It is important that this is also discussed with childbearing individuals and that the patient and partner should be provided information and education about the expected effects of treatment related to reproduction and sexual issues. Potential infertility can be a significant consequence as well, and counseling may be needed. But an important fact is that the patient should not think that conception is not possible during treatment. It is very possible, so a lot of education needs to be provided on that as well. With radiation and chemotherapies, they may cause long-term effects or late effects that occur months to years after the therapy we have discussed previously. Every body system can be affected to some extent by chemotherapy or radiation therapy. Late radiation effects occur most often in the kidneys, the liver, lungs, heart, bone, muscle, and connective tissues. The cancer survivor may be at risk for secondary cancers, including leukemia, angiosarcoma, and skin cancer. Patients treated with alkylating agents and those treated with high-dose radiation do have an increased risk. The potential risk for developing a secondary cancer does not contraindicate the use of the cancer treatment. Immunotherapy and targeted therapy. Immunotherapy uses the immune system, the body's main defense against infection, as we know, and disease, to fight cancer. Some types of immunotherapy are called biologic therapy, but immunotherapy can boost or manipulate the immune system and create an environment that is not conducive for cancer cells to grow, or it can attack cancer cells directly. Targeted therapy. This interferes with cancer growth by targeting specific cell receptors and pathways that are important in tumor growth. Targeted therapies work at sites that are on the cell's surface. So thus they act on specific targets that are associated with cancer. A major advantage of targeted therapy is that it does less damage to the normal cell. So targeted therapy provides personalized treatment based on the biology of the tumor. Targeted therapies can include these following inhibitors and antibodies. But cancer cells can become resistant to targeted therapies. Side effects of immunotherapy and targeted therapy. Common side effects do include flu-like symptoms, including headache, fever, chills, myalgias, fatigue, malaise, weakness, photosensitivity, anorexia, and nausea. Tachycardia and orthostatic hypotension are also common, but other toxic and side effects may involve the central nervous system, renal and hepatic systems, and cardiovascular system. Some problems are experienced by the patients receiving immunotherapy, and targeted therapy are different from those seen with more traditional cancer treatments. So these effects occur more acutely and are dose limited. What does that mean? That means that effects resolve when the therapy is over. Some may be afraid to discuss side effects because they think that the drug will be stopped, or they decide to stop the drugs because the side effects are just terrible. Nursing interventions for flu-like symptoms include giving acetaminophen before treatment and every 4 hours after treatment. IV Demerol has been used to often control the severe chills or rigors associated with some agents. So overall, what this is discussing is we know the possibilities of side effects that may occur. So prior to the treatment beginning, we should be educating the patients on what may occur, but that we do have a plan and that there will be medications ordered that may assist to subside the side effects or at least to bring it down a level. Now, hormone therapy. Hormones, just as background information, are substances that are made in the endocrine gland. The hormones, and this is what's interesting, is the hormones estrogen and progesterone, they can enhance the growth of some breast cancers, just as testosterone can enhance the growth of some prostate cancers. When given as a cancer treatment, the hormone therapy can block the effects of the hormone and stop the growth of cancer cells. It's kind of weird. It sounds like it's working against each other. Corticosteroids are used in combination with many other medication to treat cancer. Corticosteroids are anti-inflammatory agents that reduce swelling and inflammation, which can be contributed to cancer pain. Hematopoietic growth factors are hormone-like substances that help bone marrow make new blood cells. So, hematopoietic growth factors are used to support patients through their cancer treatment. So, colony-stimulating factors, okay? These are glycoproteins that stimulate production, maturation, regulation, and activation of cells in hematologic system. So as we just discussed, the hematopoietic growth factors are hormone-like substances that help bone marrow make new blood cells. Okay, so this may hasten recovery from bone marrow depression or re-establish bone marrow function. Hematopoietic stem cell transplantation and peripheral stem cell transplantation. These are effective life-saving procedures for the treatment of several malignant and non-malignant diseases. But both allow for the safe use of very high doses of chemotherapy agents and or radiation therapy in patients whose tumors have developed resistance or refractory or did not respond to standard doses of chemotherapy and radiation. So this therapeutic approach was referred to as bone marrow transplant because the bone marrow was the original source of stem cells when the procedure was first developed. However, advances in harvesting and cryopreservation technologies have opened new pathways to the collection of stem cells from the peripheral blood. The approach to hematopoietic stem cell transplantation is to eradicate diseased tumor cells and or clear the bone marrow of its components to make way for engraftment of the transplanted healthy stem cells. So just to make it easier, I'm just going to start stating HSCT instead of saying hematopoietic stem cell transplants because it's a mouthful. So the HSCTs are characterized, they're allogenic, syngeneic, or autologous. The sources of stem cells include bone marrow, peripheral circulating blood, and umbilical cord blood. So let's break down what these categories are. So allogenic transplant, these are stem cells are acquired from a donor whose tissue typing has been determined to be a match to the recipient. Okay. The syngeneic transplantation is a type of allogenic transplant that it involves obtaining stem cells from one identical twin and infusing them into another because identical twins have identical tissue types and are a perfect match. That's syngeneic. Autologous, autologous transplantation is where patients receive their own stem cells back after myeloablative. This is also known as destroying bone marrow chemotherapy. The aim of this approach is to purely rescue. It's allowed patients to receive intensive chemotherapy and or radiation by supporting them with their previously harvested stem cells until their own marrow is able to generate blood cells again on its own. So that's kind of a breakdown of the categories of HSCT. So let's talk about the procedure. The procedure used for harvesting stem cells from the bone marrow is done in the operating room using general or spinal anesthesia. Multiple bone marrow aspirations, which is usually taken from the iliac crest, but sometimes the sternum, are carried out to obtain stem cells. So the harvested marrow is processed to strain out bone fragments. The entire bone marrow harvest procedure can take about 1 to 2 hours, and then the patient is discharged after recovery. Cells are cryopreserved until infused. Peripheral stem cell transplants, these are obtained from the peripheral blood in an outpatient procedure. It's done by using cell separator equipment that automatically separates the stem cells from the blood circulating through the machine and returns the remaining blood components to the donor. And this process takes about 2 to 4 hours. It's almost when you go to I forget what their names are, but it's where you donate blood and you are just donating plasma. So it'll remove the plasma from the blood but return the blood back to you. That's how I remember this. But often it does take more than one procedure to obtaining of stem cells. And that's because the blood has fewer stem cells than the bone marrow. Umbilical cord blood is rich in hematopoietic stem cells. Successful allogenic transplants have been done using this source. So cord blood can be HLA typed, which is human leukocyte antigen typed and cryopreserved. There is a disadvantage of cord blood, which is the possibility of insufficient numbers of stem cells to allow transplant to adults. Currently, there is research ongoing to define the optimal use of this technology. Now, this is a lot of information and can be confusing, but patients receive myeloablative dosages of chemotherapy with or without adjunctive radiation to treat the underlying disease. Okay, so total body irradiation, or TBI, can be used for immunosuppression or to treat the disease. These preparative therapies are known as conditioning regimens. So bacterial, viral, and fungal infections are common after HSCT. Prophylactic therapies are used to reduce their incidence, but a potential serious complication of allogenic transplant is graft versus host disease. And for me, this makes sense. This occurs when the T cells from the donated marrow or the graft recognizes the recipient as foreign and begin to attack certain organs. Organs such as the skin, the liver, and the GI tract. Gene therapy. This is an experimental type of therapy that involves introducing genetic material into a person's cell to fight disease. But at this point, this is investigational and not too much information is out there or definitive information. Patients with cancer, they may develop complications related to continual growth of the cancer into normal tissue or the side effects of the treatment. As we've discussed throughout this chapter, there are many complications, many side effects, and many issues that can occur with the use of these different types of therapies to fight cancer and radiation therapy. As we've kind of discussed with different areas of this chapter, nutritional problems are a complication of cancer. So with malnutrition, obviously, because we have discussed nutrition as a whole, the patient with cancer may have protein and calorie malnutrition characterized by fat and muscle depletion. So we need to assess malnutrition as we have discussed in our previous chapter. So once we do our assessment, we need to teach the patient to avoid extremes of pressure, temperature, tobacco, alcohol, spicy, or rough foods. And we need to encourage nutritional supplements like Ensure as an adjunct to meals and fluid intake. The patient needs to be weighed at least twice each week to monitor for weight loss. This is also another complication of cancer. It's altered taste sensation. So, cancer cells may release substances that stimulate the bitter taste buds. So our patient may have changes in their sweet, sour, and salty taste sensations. So for the patient, their meat may taste bitter or bland. It is unknown what the cause is. What we can do is teach our patients with altered taste problems to avoid foods that they dislike. And we can also encourage our patients to try different ways to mask the taste changes, maybe find some stronger seasoning and spices that may be effective. Cancer cachexia or wasting syndrome. This is a multifactorial syndrome characterized by anorexia and or unintended loss of weight and appetite. It's accompanied by generalized tissue wasting, skeletal muscle atrophy, immune dysfunction, and metabolic problems. So the best management of cancer cachexia is to effectively treat the cancer. What is unfortunate is that this is not a realistic goal for patients with advanced cancer. In a sense, we know that infection is an obvious type of complication that can occur with cancer. So infection is the leading cause of death in the patient with cancer. The usual sites of infection include the lung, the GU system, the mouth, rectum, peritoneal cavity, and blood, in other words, septicemia. Infection occurs because of the ulcerations and necrosis caused by the tumor compressing vital organs, and neutropenia from the cancer or the cancer treatment. So, unless we can place our cancer patient in bubble wrap and everything else, we just need to teach the patient about infection, the usual sites, the signs and symptoms, and what they should do. Sorry, I kind of got ahead of myself with infection, but I just described these things on the last slide. So oncologic emergencies are life-threatening emergencies that can occur because of cancer or because of cancer treatment. These emergencies can be broken down as obstructive, metabolic, or infiltrative. Let's kind of discuss each. So obstructive emergencies are mainly caused by tumor obstruction of an organ or a blood vessel. Okay, so obstruction. Our metabolic emergencies are caused by production of ectopic hormones directly from the tumor or from metabolic problems caused by the cancer or cancer treatment. And lastly, our infiltrative emergencies occur when cancer it infiltrates major organs or from cancer treatment. So obstructive, metabolic, and infiltrative. Cancer pain. So patients should be strongly encouraged to report any pain that they are feeling, and patients' report should always be believed and accepted as primary source for pain assessment data. Drug therapy should be used to control pain. So moderate to severe pain occurs in about 50% of patients who are receiving active treatment for their cancer, and in 80 to 90% of patients with advanced cancer. So overall, undertreatment of cancer pain is common. It causes needless suffering, decreases quality of life, and increases the burden on the caregiver. So inadequate pain assessment is the single greatest barrier to effective pain management. So fear of addiction is unwarranted or is not justified at this point. Numerous drug options are available for for pain managers such as opioids, and also non-pharmacologic interventions, including relaxation therapy and imagery, can be used effectively, as well as NSAIDs like ibuprofen, like I mentioned, opioids like morphine, Dilaudid, analgesic medications, sometimes fentanyl should be given on a regular schedule. So there are different types of pain management for our cancer patients. So as the nurses, we need to make sure that we have this conversation with the patient, allow them to express their feelings in regards to pain and pain management, because this is patient-centered and the patient should always be in charge of their plan of care. So culturally competent care for cancer. So we have a lot of underserved populations that are at risk for late stage disease at time of diagnosis. So we have to, as the nurses, collect information, provide what the support and advocacy that the patient may need, and we must look at the patient as a whole person, not just the cancer disease process, as well as we have to look at the variables that may affect that patient. They could very little access to health care, no insurance, fixed income, underserved population. So as nurses, we need to know how to assess for cultural differences, identify barriers to care, and adapt care to meet the specific cultural needs.